Welcome to Advances in Allergy and Asthma. This webinar series helps Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. It is presented in partnership with the American College of Allergy, Asthma, and Immunology. This is Sally Schessler, Director of Education for Allergy and Asthma Network, and I am pleased today to introduce Dr. Kelly Maples, who will lead our discussion about atopic dermatitis and skin of color. Born in Pennsylvania, Dr. Kelly Maples grew up in New Jersey and graduated from Rutgers University. After graduating from Temple School of Medicine in Philadelphia, she moved to Norfolk, Virginia with her fiancé for residency in internal medicine at Eastern Virginia Medical School, where her now husband Christopher served in the U.S. Navy. After residency, she completed an allergy and immunology fellowship at Virginia Commonwealth University in Richmond, Virginia, where she worked on research focusing on eosinophilic esophagitis. She then returned to Norfolk, where she now serves as an associate professor of pediatrics and internal medicine at Eastern Virginia Medical School and Children's Hospital of the King's Daughters. She also serves on the American College of Allergy, Asthma, and Immunology Board of Regents and is chair of the Dermatology Committee. She also serves on the ACAAI Executive Committee. She lives in Suffolk, Virginia with her husband, 3 children, and 2 doodles. Dr. Maples, thank you so much for being here today. We're really looking forward to learning something new from your presentation.
Thank you so much for having me, Sally, and thanks for your introduction. Let's get business over with. This is my disclosure slide. I serve on 2 advisory boards, and there's no conflict of interest with today's talk. So I'm really grateful that I'm getting to talk about an important topic that I believe addresses a significant gap in the medical education of many of us. Here's a brief outline of my talk today. We know that atopic dermatitis in skin of color is more prevalent and often more severe, and it can present with different appearances and morphologies than atopic dermatitis in white skin as a result of pigmentary and immunologic differences. And we should take all of these into consideration when we develop diagnostic and treatment strategies for patients with atopic dermatitis in skin of color. So let's start with the best part of our job and the most important part of our job, patient. So here's Jack. Jack's a 14-year-old boy. He's a freshman in high school. He plays soccer. He's here to see you today because he's having really itchy patches on his arms and legs. They're getting frustrating to him. He doesn't like how they look when he wears short sleeves and shorts, and he's really uncomfortable. He saw his primary care doctor, who diagnosed him with dry skin and told him to put Vaseline on a few times a day. But Jack says that's just not helping. So he's here to see you. And in the lower photo, we see an example of similar patches on his other arm and both legs. So take a look at this and think about, how would you describe this? What do you think this represents? Is this active inflammation? Do you think he just has dry skin? Do you think this is some post-inflammatory hyperpigmentation? And what treatment would you recommend based on your physical exam evaluation that you, from what you can see here? And we'll get back to Jack and talk about him more. Later that day, Tracy comes to see you, and she's a pleasant woman in her late 20s, and she's here because she cannot sleep at night. She is very, very itchy. She's itchy all over her body, but especially her torso. The itching's gotten so bad that she's having a hard time getting up for work in the morning, so she started to take sleeping pills so she could fall asleep. She's using a sensitive skin soap and a free and clear detergent, as well as a thick emollient recommended by her primary care doctor, but it's just not helping. So she's here to see what you can do. And on the left, we can see some of her physical exam. So take a look at her skin, and do you see post-inflammatory changes, dry skin? Do you see eczema, psoriasis, normal skin? And we'll come back to her as well. So as many of you know, eczema is really common. Eczema is the most common skin disease in the general population in the United States, and in less than more than half of the US population will have skin of color. And eczema is more common in skin of color. So it's really important for us to know how to identify and care for eczema in skin of color. When we look at prevalence in adults, about 3 to 4% of European Americans have atopic dermatitis. About 7 to 10% of adults in Asian countries have atopic dermatitis, and about 19% of African American adults do. And in the United States, the prevalence is higher among Black children than among white children. And patients with atopic dermatitis seek care more often than white patients with patients with skin of color with atopic dermatitis care more often than white patients do, and that's thought to be because their itching is more severe. So on a per capita basis, Black patients are about twice as likely to visit a doctor for atopic dermatitis as white patients, and Asian American and Pacific Islander patients are about 6 times as likely as their white counterparts to visit a doctor for atopic dermatitis. And this was not due to greater healthcare utilization. In fact, the Black and Asian American Pacific Islander patients in the study had less healthcare utilization overall for other conditions, but just higher for atopic dermatitis. And although Black and Asian American patients saw doctors more often for atopic dermatitis than white patients did, this was not the case for other skin disorders, as you can see here. So there's something about atopic dermatitis in these populations that causes them to have more severe itching and more treatment-resistant disease that leads to more visits to healthcare providers. So a lot of my talk today is going to focus on the clinical presentation, especially the visual presentation of eczema. If we want to provide good care for atopic dermatitis in patients of skin of color, the first thing we need to be able to do is to diagnose them, to identify the atopic dermatitis and to identify their severity appropriately. And there's many visual differences. The color of atopic dermatitis can appear different on richly pigmented skin, but we'll also see different morphologies and sequelae. So erythema is a feature that we all look for when we're assessing skin for atopic dermatitis. And here's a quick definition that many of us are taught of erythema. Abnormal redness of the skin or mucous membranes due to capillary congestion as an inflammation. So when many of us think of erythema, we think of the color red. Here I have some screenshots of searches I did looking for images of atopic dermatitis in skin of color. I looked for erythema on the face in the picture on the far left. Then I looked for erythema and eczema, and you can see those photos. And then I looked for erythema and eczema in skin of color. And as you can see, all of these fit that classic definition of red as a representation of erythema. And unfortunately, even when I looked for erythema in color, most of the images were of white skin. And this was just a Google search, but even in medical textbooks and many journal articles, it focuses on the appearance of atopic dermatitis in white skin. So one thing that I want people to take away from today's lecture is that erythema does not always present as redness. If you remember just that, you'll be able to take better care of patients with dark skin who have eczema. Before I go any further, I want to take a moment to thank Dr. Andrew Alexis. Dr. Alexis is a professor of dermatology at the Icahn School of Medicine, and he practices at Mount Sinai. In 2019, I had the pleasure of attending a lecture that he gave about atopic dermatitis and skin of color, and I was truly moved by it, and I felt that it was practice changing. And then last year in 2020, I saw a virtual presentation of his during the pandemic about the presentation of various allergic skin diseases in skin of color. And when I was preparing my slides for this presentation, I wanted to focus on visual images because we don't see enough of those in our education. And I really couldn't find enough. So I reached out to Dr. Alexis, and he very kindly allowed me to use his images for this presentation. And I believe his images are more valuable than my words today because we don't see that many clinical images of atopic dermatitis and skin color in our education. So I would like to thank him, and if you ever have a chance to attend one of his presentations, I encourage you to do so. So back to our discussion of erythema. So the second part of the definition that I brought up was that it results from congestion due to inflammation. So there is that increased blood flow, but in richly pigmented skin, the melanin overlying that congestion can make that erythema appear colors other than red. And if you just look for redness, you might miss the diagnosis or underestimate the patient's disease severity. So here on the right, we see Mark's photo again. And his degree of erythema in this photo is equivalent to the degree of erythema on the left. So the photo on the left is that classic red erythema that we think of. But his erythema has a gray or a gray-brown hue. He also has some follicular lesions and some scaling and lichenification. We can't palpate his skin, but we do know from the history that it's very itchy. So this wasn't hyperpigmentation or post-inflammatory changes, but this truly represents erythema and active atopic dermatitis. Oh, excuse me. So reliance on erythema scores can mask severe atopic dermatitis in Black children compared with white children. So a study was done using SCORAD scores, and they found that the classic SCORAD scoring system underestimated disease severity of Black children with atopic dermatitis, but not of white children. So then a modified erythema score was created into account the different appearance of erythema in darker skin. And when using the modified erythema score, then the SCORAD score could adequately identify the severity of eczema in Black children. We certainly don't have time to do SCORAD scoring in all of our patients, and we don't need to in clinic, but we should all try to modify our own erythema score or kind of recalibrate our eyes on how we look at erythema and how we erythema. And as I've alluded to throughout the presentation so far, there is a lack of clinical images of atopic dermatitis in skin of color that's led to a gap in medical education for many of us. In addition to skin color changes, there can be unique morphologies of atopic dermatitis in patients with skin of color. And these are certainly generalizations, and this is from a paper published by Dr. Leung. White patients tend to have atopic dermatitis, tend to have ill-defined erythematous scaly patches. In contrast, Asian patients tend to have very well-defined, well-demarcated erythematous plaques, often with overlying that can appear a lot like psoriasis. And Black patients, in addition to not having different appearance to their erythema, they also tend to have follicular lesions that represent active eczema and suffer from more lichenification than their white counterparts. So here are some clinical images of atopic dermatitis in children from a recent article published in New England Journal just this year. And I was very happy that they included images of skin of color. In panel C, we see a child with atopic dermatitis, and we see lichenified, scaly patches in his popliteal areas. The erythema has a purple or gray hue, and we can contrast that to the erythema in the child in photo D. So because of his darker skin, the erythema is still there, it just looks different. So if you know what to look for, you see it. One thing you can do is to look at his normal skin on his lower leg and stare at that for a few seconds, and then look at his active eczema to kind of recalibrate your eye to help see the color change. In panel G, we see a follicular papular morphology of atopic dermatitis, which is more common in African American patients. On the periphery of this child's torso, we see a brown shade of erythema with some brown follicular eczema. And then in the center, we see a gray or purple appearance to the erythema. And then we have papulonodular lesions that are coalescing into plaques with some overlying lichenification, especially in his lower abdomen. These are some photos that Dr. Alexis provided to help us start to be able to look for erythema and other skin changes in African American skin with atopic dermatitis. So in the photo on the left, we see red-brown papules coalescing into plaques, and some redness is obvious with this erythema, but a lot of it is brown. On the patient on the right, we see a woman who's having an atopic dermatitis flare on one leg, but not the other. And the skin helps us see helps us see the erythema a little bit better. When we calibrate our eyes to her normal skin and then look at the involved skin, it's more noticeable that she has a purplish gray appearance to her erythema. And we would also palpate this, look for lichenification and scale, and get a history of itching. On her lower legs, you may notice some depigmentation, and I will discuss that in a future slide. Here we see other presentations of atopic dermatitis in darker skin. On the left, we see a violaceous hue of eczematous lichenified plaque with excoriation. And on the right, we see another example of some red-brown appearing erythema. And this is an appearance that's often misdiagnosed as hyperpigmentation. This is active eczema. And once again, we would palpate, we would compare her involved skin to her uninvolved skin, always get a history, which is so important, looking for identification. But this brown area is active erythema and active atopic dermatitis. Here we're back to Tracy, our patient that I presented at the beginning, and she has severe atopic dermatitis affecting a large surface area of her back, and she has very dark skin, so she really doesn't have any of that red-brown appearance. She more has circles replaced by Dr. Alexis, and there's some islands of normal skin that we can look at to calibrate our eye when we're looking at the rest of her skin. And I'm going to talk about treatment later on in the talk, but I wanted to include this photo here because this is Tracy 9 months after DUPILUMAB treatment. So her itching's much better and her skin is almost clear. But by looking at that photo, we can compare it to the original photo, and that helps us calibrate our eye to look for that purple and gray erythema that she was having. Here's another photo of a gentleman with severe atopic dermatitis. Most of his lesions have a purple-gray appearance to the erythema, but he does have some reddish nodules as well. So the goal of the photos that I've showed you is to broaden your palette of colors that can represent erythema to help you be able to recognize erythema in shades other than red. And when we're examining patients with black skin who have atopic dermatitis, there's differences beyond color. So a micropapular or follicular presentation is more common in black patients with eczema. And on the photo on the left, we see a person with active, very itchy eczema who presents with 1 to 2 millimeter follicular papules without any redness or lichenification, no scale. But this is not follicular accentuation. This is actual eczema. So sometimes children who present this way are misdiagnosed and then as a result undertreated. So that's a presentation to be aware of. In the photo on the right, we see some larger papules with some more clear erythema. And these were biopsies and confirmed to be atopic dermatitis or a spongiotic dermatitis on biopsy. A lichenoid appearance to atopic dermatitis is also more common in African American patients. And when that occurs, it's often on extensor surfaces, as we see on the photo on the left, and it can have a purple or violaceous hue. It can look a lot like lichen planus, so history is really important. A lot of times by history, it's clearly atopic dermatitis, but sometimes a biopsy is needed. So in the photo on the right, on this patient's hand, that was biopsied and was found to be atopic dermatitis as opposed to lichen planus. So it's another appearance to be aware of. An additional morphology that we see more often in African American appearance is that papulonodular or nodular appearance of atopic dermatitis. On the left, we see brown erythema with nodular lesions. Prurigo nodularis is the common sequela of atopic dermatitis in African American patients to be aware of. And on the right, we can see reddish brown to purple papulonodular lesions that have coalesced into a large lichenified plaque. So these are some other good images. Patients with darker skin are more sensitive to pigmentary changes. So all patients with atopic dermatitis can develop hyper or hypopigmentation as a result of their disease or their treatment. But if you have darker, it's more noticeable. So it adds more to the burden of disease than it does often in patients with lighter skin. On the photo on the left, we see hypopigmentation and atrophy due to overuse of potent topical steroids. So that's something to think about in treatment. And the photo on the right is not vitiligo. It's actually permanent depigmentation from years of scratching. So we know that scratching can harm the melanocytes in skin. And when atopic dermatitis isn't adequately controlled, permanent depigmentation can be a sequela. Here's a photo of an Asian presentation of atopic dermatitis. So this gentleman has well-demarcated, scaly, erythematous plaques with some thick scale on his left shoulder that can look very psoriasiform or like psoriasis. I unfortunately don't have that many photos of Asian atopic dermatitis because they're hard to find, but in a future section, I will have a few more photos. So any discussion of atopic dermatitis wouldn't be complete without discussing the role of the skin barrier. And we know that atopic dermatitis pathogenesis is driven by a combination of both immune dysregulation and impaired epidermal barrier integrity. So they're both important. So these are some schematics of the epidermis that I often attempt to draw for my residents when I'm teaching them about why different skincare measures are important in atopic dermatitis. So in the center, we see this brown schematic. It's a very simplified version of the epidermis with a nice fat, plump cell full of cytoplasm at the basal layer, the dermal epidermal junction. And as you move superficially, these superficial keratinocytes are free of cytoplasm and they're full with keratin bundles. You'll see these little blue joiners between each cell. They are specialized desmosomes called corneodesmosomes. And the corneodesmosomes provide an important part of the epidermal barrier. They help hold those keratinocytes together. And the corneodesmosomes are regulated by proteases that break them down when necessary, and protease inhibitors feed back on those proteases to balance the breakdown of these corneodesmosomes. That's all pH balance. So the reason I tell you that is because the pH of soap is very alkaline and can affect these corneodesmosomes, as I'll show you in the next slide. So on the left side of this slide, we see the classic brick wall analogy of the epidermal barrier. So each of the individual bricks represents the keratinocytes. This rebar holding the bricks together can represent the corneodesmosomes, and then all of this yellow mortar between the bricks holding them together represents the lipid lamella portion of the epidermis. The lipid lamella is full of lipids that help hold water in and keep irritating things out of the skin, and it's composed of ceramides and hyaluronic acid and cholesterol. In panel C here, this is a representation of what the wrong kind of cleanser can do to the skin barrier. So the alkaline pH of soap activates those proteases that break down the corneodesmosomes and inhibits the protease inhibitors. So it leads to more skin barrier breakdown in an already impaired skin barrier. And detergents, things like sodium lauryl sulfate, things that make bubbles in our shampoo and in our body washes that people like to see, that can dissolve this lipid lamella and further break down the skin barrier. So when the skin barrier is broken down by soaps and detergents, infectious agents and allergens can penetrate the epidermis and lead to inflammation. And what's not shown in this photo, it also, when the skin barrier breaks down, there's more evaporative loss, what we call the increased transepidermal water loss. So all of these things are important when we're addressing skincare. It's important to use a nice thick cream or ointment-based moisturizer to apply after the bath. This will help prevent transepidermal water loss. Lotions have a high water content and don't do as good of a job at sealing the water in the skin. They're not as occlusive. They don't prevent transepidermal water loss as well. And also in patients with moderate to severe atopic dermatitis, we want them to avoid soaps and detergents in their cleansers. There's also a few treatments now that are prescription devices that help rebuild the skin barrier, but there's many emollients that are available over the counter that contain ceramides and other lipids in the lipid lamella to help rebuild the skin barrier. So filaggrin is an important component of the skin barrier. Filaggrin is filament aggregating protein, and it's the major structural protein of the stratum corneum, and it plays an important role in epidermal homeostasis, so it's not just structural. Filaggrin breakdown products help with keratin processing and filament organization in the keratinocytes. They help form the lipid lamella. They help with water retention and overall epidermal barrier integrity. Filaggrin loss of function mutations are the most common genetic susceptibility to atopic dermatitis that's been identified, but at least half of patients with atopic dermatitis do not have a mutation in filaggrin. It's estimated that 10 to 50% of patients with atopic dermatitis have a filaggrin loss of function mutation, and that's higher in the white population at about 30 to 50% of those, it's estimated. But even in patients with no mutation in filaggrin is decreased in both lesional and non-lesional skin in people with atopic dermatitis. So even if they have a normal filaggrin gene, they have less filaggrin in their epidermis. And that's thought to be due to multiple inflammatory cytokines. So Th2 cytokines like interleukin-4 and interleukin-13 are thought to decrease filaggrin expression, but other cytokines, including interleukin-17 and interleukin-22, which I'll talk about more as well, also are thought to decrease filaggrin expression in both lesional and non-lesional skin in atopic dermatitis. So I talked about a lot of visual differences, but there's also different immunoendotypes or genotypic differences in atopic dermatitis in patients with skin of color. The most recent article in New England Journal on atopic dermatitis very briefly addresses this. And as you'll see under essential features, under immunoendotype, they note that there's increased Th2 cells in white and black patients with atopic dermatitis, and increased Th2 and Th17 cells in Asian patients with atopic dermatitis. But in the past, more detailed studies were done. So in 2015, Dr. Liang did a comparison of East Asian patients with European American patients with atopic dermatitis. Visually, he reported that Asian subjects had, as I mentioned before, well-demarcated erythematous plaques that often appeared like psoriasis. He found that their skin lesions had increased Th17 and Th22 activity, so things that can decrease filaggrin expression. And on biopsy, they had a more psoriasiform histology as opposed to European American counterparts. Of note, lesional biopsies from both the East Asian patients and the European Americans both showed Th2 polarization. And that's important because the Th2 cytokines are a therapeutic target that we can manipulate now. They didn't study the immunoendotype in African American patients with atopic dermatitis at that time. The Asian eczema phenotype has been called a blended phenotype because visually it can present like a combination between eczema and psoriasis, and we see that on biopsy as well. They have elongated retained pegs, hyperplasia, and parakeratosis. We know that there's few studies done subsequent to Dr. Liang's 2015 study, once again confirmed higher Th17 and Th22 activity in Asian atopic dermatitis skin. And we think this might be why their skin has more of a psoriasis appearance, because interleukin-22 and interleukin-19 are known to induce epidermal hyperplasia and parakeratosis. But it's been confirmed again that they still do have a strong Th2 component, so that can be important when we're targeting treatment and considering treatments such as DUPILUMAB. There are drugs that are work against interleukin-17 and interleukin-22 being studied now. So monoclonal antibodies against interleukin-17 and interleukin-22 are in clinical trials, and this may be a promising target, especially for Asian patients with atopic dermatitis. Here we see a comparison of Asian atopic dermatitis and European American atopic dermatitis. So in the photos, we see well-demarcated scaly plaques in the Asian patient with atopic dermatitis, and more ill-defined erythematous patches in the white patient with atopic dermatitis. And on biopsy, we can't see very close up, but you can see the elongated rete ridges and the hyperkeratosis that are very, very similar to psoriasis in the Asian biopsy that we don't see in white patients with atopic dermatitis. So shifting to the African American and a type of atopic dermatitis. The African American eczema has been described as treatment-resistant and lichenified phenotype. Unlike white patients or European American patients with eczema, filaggrin loss of function mutations are not common in African American patients with atopic dermatitis. And as I mentioned before, at least half of patients with eczema don't have one of those mutations. There have been filaggrin variations identified in African American patients with eczema, and those patients tend to have more persistent disease. African American patients also showed an upregulation of Th22 activity compared to white patients, but not as significant as their Asian counterparts did. So interleukin 22 may be a therapeutic target for African American patients with atopic dermatitis as well, and we'll be discussing treatment shortly. So here's another photo comparing Asian atopic dermatitis on the left, and then African American atopic dermatitis in the second column, with psoriasis on the end. So both African American and Asian patients do have increased Th2 activity, but Asian American patients have a marked increase in Th22, more than their African American counterparts. Asian patients also have increased Th1 and Th17 expression in their lesional skin, where African American patients with atopic dermatitis did not. So the Asian phenotype is very similar to psoriasis, that so-called blended phenotype I alluded to earlier. So treatment. The most important thing when treating patients with atopic dermatitis and skin of color is to make sure we're treating the right thing. We don't miss the diagnosis, and we don't want to underestimate the severity. By avoiding under treatment, we can improve their quality of life, we can prevent flares, and we can prevent sequelae. We recall lots of patients can't sleep because they're so itchy, or they wake up several times per night. They're uncomfortable during the day. They're self-conscious about how they appear. Sequelae like hypopigmentation is more obvious in darker skin, so we want to try to prevent that. And always start with the basics. So address the skin barrier. Make sure they're using gentle cleansers, especially if they have moderate to severe disease. Avoid soaps and detergents. Use a good aggressive moisturizing regimen, preferably cream and ointment-based emollients that contain ceramides to help with the epidermal barrier function. And now there's prescription topical barrier devices that can help repair the epidermal barrier as well. We need to target inflammation, but we have to balance that with the overuse of potent topical corticosteroids, because we don't want to cause skin lightening or atrophy. So consider other topical inflammatory measures as well, including topical calcineurin inhibitors and PDE4 inhibitors, as well as DUPILUMAB. If we address good skin care and good anti-inflammatory therapies while minimizing overuse of topical corticosteroids, we can help address their dyspigmentation concerns and help control the itch, which we know is worse in Asian and African American patients with atopic dermatitis. So although Asian patients have much higher Th22 expression and as well as Th17 expression, and African Americans have some increased Th22 expression, all patients with atopic dermatitis share that common overexpression of Th2 and Th2 cytokines in their skin. So DUPILUMAB is a good treatment for all of them. Recall DUPILUMAB is a monoclonal antibody against the interleukin-4 alpha receptor, and that blocks the activity of two important Th2 or two important allergic cytokines, interleukin-4 and interleukin-13. And DUPILUMAB has really kind of changed the treatment of moderate to severe eczema, where our goal now can be clear skin or almost clear skin instead of just kind of trying to control it. So this is effective in eczema and skin of color as well as white patients. On the left, we see a gentleman who had severe atopic dermatitis for many years. In the photo on the left, he was on multiple topical anti-inflammatories, but you see 6 months after treatment with DUPILUMAB, he was significantly improved, both visually and much less pruritus. And then we're back to Tracy, who we see once again improved very significantly after 9 months of Dupixent, no longer needing to take sleeping pills, comfortable in her skin and not itchy. So another DUPILUMAB success. Here's a chart of treatment for atopic dermatitis in the most recent article from New England Journal that I cited, and it talks about the basics, which are really important: avoidance of triggers, and emollients, using topical anti-inflammatories, but I wanted to point out some future therapies. So Janus kinase inhibitors, both oral and topical, are pending approval for atopic dermatitis. Oral Janus kinase inhibitors are currently used for disease states like rheumatoid arthritis. Janus kinase 1 inhibitors decrease the Th2 cytokines interleukin-4 and interleukin-13, but they also decrease interleukin-31, which is a very important mediator of itch. That's the most important source of itch in atopic dermatitis, we think. And Janus kinase inhibitors inhibit interleukin-22. So this might be a good therapeutic agent to target Asian atopic dermatitis that has very elevated expression of interleukin-22, and also African American patients who have a lot of itching because it targets interleukin-31 and they have some increased Th22 activity as well. There is an interleukin-22 receptor antibody being studied for atopic dermatitis as well. This chart's a very good thing to go over, but these are the ones that I wanted to point out, particularly for skin of color. Whenever we have a patient with moderate to severe atopic dermatitis, especially if they're not improving with treatment as we expect, we always want to consider patch testing to look for allergic contact dermatitis, because these patients can develop allergic contact dermatitis to their topical corticosteroids or to their personal care products. So if we can identify triggers, we can help them avoid those and help improve their skin. When you're reading patch tests in darker skin, you want to recall the limitations of classic erythema. Look for the other colors like brown and gray and purple that can represent erythema in darker skin. And you may need to add palpation or silating. So if you palpate each patch result, you want to palpate for induration and edema, and silating can also help you see elevations in the skin that represent edema and induration. Here we see a patient who had a positive patch test to nickel. Around the edges, she has some brown to red erythema, but the indurated area is more of a silver or gray. So in summary, atopic dermatitis is very common, and it's more common in skin of color. It can present with different colors and different morphologies. We want to expand our palette of what our definition of erythema is and look for other colors. Remember that they could have the follicular appearance, papulonodular appearance, lichenoid appearance, and prurigo nodularis in Black patients with atopic dermatitis. Asian patients with atopic dermatitis may have a psoriasis-like appearance with well-defined erythematous plaques with scale. Atopic dermatitis tends to cause more severe symptoms and itching in skin of color, and they do seek more medical care for it, even though they're not seeking more medical care for any other problem. We don't want to miss or underdiagnose undertreat their atopic dermatitis, so reviewing clinical images of the appearance of atopic dermatitis and skin of color is important. And there's new treatments that are target atopic dermatitis endotypes in skin of color, such as Janus kinase inhibitors and interleukin 22 and interleukin 31 antagonists are being studied. So it's an exciting time to take care of these patients. I'm very happy to say that through a joint effort of the American College of Allergy, Asthma, Immunology and the Asthma and Allergy Network, there's going to be a microsite addressing social disparities in eczema care on the website for the American College of Allergy, Asthma, and Immunology. And in there, you'll find more clinical images of atopic dermatitis and skin of color, so you can improve your diagnostic ability. And that should be available hopefully sometime in August. So thank you very much for taking the time out of your busy day to listen, and I hope you all learned something. I am happy to take any questions.
Oh, thank you so much, Dr. Maples. We totally appreciate everything you had to not only say, but show us. The pictures were stunning. I'm so glad you were able to get those. It was really, really very descriptive with that help. So we do have questions, and the first question is, when should people of color see a specialist for treatment?
So when basic skincare and basic topical anti-inflammatories aren't providing adequate relief, or if the patient's atopic dermatitis is really affecting their quality of life, that's when I think that you should consider sending them to a specialist, either an allergist, immunologist, or a dermatologist. So if they're not responding to good skincare and mild to moderate topical corticosteroids or topical calcineurin inhibitors, if they can't sleep, if they're concerned about their appearance, then we'd be happy to see them. And besides addressing those concerns, we can help identify triggers and help them avoid their triggers as well.
Thank you so much. So how should eczema be treated in people of color?
So eczema and skin of color should be treated right now about the same as eczema in all patients, but there are special considerations. When we're treating patients, we want to make sure we're treating the right thing. Sometimes dark brown spots might be mistaken for post-inflammatory hyperpigmentation, and then we would just tell patients to use a moisturizer, whereas it may represent active atopic dermatitis. So the first part when treating them is to make sure you're not missing anything. Then you always want to start with the basics, start with a good skincare regimen. If they have moderate to severe eczema, in order to protect their epidermal barrier integrity, suggest using soap and detergent-free cleansers. After the bath, emollients are essential, but we want a thick cream or ointment-based moisturizer, preferably one that contains ceramides to help restore epidermal barrier integrity. That should be applied after the bath, but then depending on the severity of their eczema, several times per day. Topical anti-inflammatories are often necessary. When you use topical corticosteroids, a special consideration in skin of color is avoidance of overuse of higher potency topical corticosteroids, because hypopigmentation can be more obvious in skin of color, so it's often more bothersome to patients with skin of color. So consider topical calcineurin inhibitors and phosphodiesterase inhibitors. And then if they're still difficult to control, currently, we have one biologic available, which is very helpful, DUPILUMAB, which targets the interleukin-4 and interleukin-13 and decreases Th2 cytokines. And many patients with moderate to severe eczema are able to achieve clear skin or almost clear skin, something that we didn't really think was possible before. And hopefully, in the not too far off future for skin of color, we'll have possible other therapies such as interleukin-22, which is something that's overexpressed, especially in Asian skin with atopic dermatitis, and the Janus kinase inhibitors can decrease interleukin-22 and interleukin-31, because we know that patients with skin of color, both Asian American, Pacific Islander, and Black patients tend to have more severe pruritus. So interleukin-31 is being studied for atopic dermatitis and shows a lot of promise for decreasing itch.
Oh, thank you so much. So our next question is, what is the prevalence of atopic dermatitis in Hispanic people? Is the presentation in Hispanic people distinctive, or is it similar to other populations?
So unfortunately, I only focused on Asian and Black patients with atopic dermatitis because that's what I could find in the literature. And, even with photos, I have photos of Asian patients because it's very hard to find them. So it's definitely a gap in our education. So I didn't address other ethnic groups because I couldn't find good data.
Oh, thank you so much. Our next question I can handle. Is it going to be possible to get a recording of this presentation? And the answer to that is yes. It'll be posted on our website, usually within about 48 hours. If you go to allergyasthmanetwork.org, look for news and then webinars, and you'll find the recording there. And somebody's saying, why no study for African Americans? I'm not sure, how that applies, since we were talking about studies. Do you understand what that question might be addressing?
I'm not sure if they mean like drug studies. And a lot of times they don't. I don't have pharmacy data about interleukin-22 or Janus kinase inhibitors, particularly in African Americans. I do have the studies we talked about that African Americans have increased Th22 in their skin, but not increased Th1 or Th16, unlike Asian patients. And we know they tend to have more itch, and they tend to have more doctor's visits despite for eczema because their itch is so bad, even though they overall have lower healthcare utilization. So eczema has been studied in African American patients. I agree it needs to be studied more, and we need more clinical images. But if the person asking the question was asking about particular medications, I don't have access to any of that.
Okay. Our next question is, can you please repeat what you said about taking a shower, about applying lotion with water on your skin?
So it's good to apply. Patients with eczema have impaired skin barrier integrity, and that's across all different skin colors. So part of the job of a healthy skin barrier is to hold water in. And when patients have skin barrier dysfunction, the water evaporates too fast. We call it increased transepidermal water loss. And right after a bath or a shower when our skin is damp is a great time to put moisturizer on because it can help trap more water in the skin. So we want to use occlusive moisturizers. They're usually a cream or ointment based form. Lotions have a lot of water, so they're not really occlusive. And if you put them on right after a shower, they'll evaporate along with the bath water. So I tell patients to lightly pat dry. We don't want to rub. We actually know that even rubbing with the towel can increase inflammation in skin with eczema. So just pat dry, and when their skin is still damp, get a nice thick layer of one of those cream or ointment-based moisturizers. My preference is one that contains ceramides because that's a key component of the lipid lamella portion of our epidermal barrier.
Our next question leads right into that. Do you have cleansers or soaps that you recommend? What about creams and emollients?
So for soaps and cleansers, I recommend soap and detergent free. Am I allowed to say brand name, Sally?
Technically, no, because this is for CE.
Right. Yes. I don't think I can give you exact products, but I like things to be soap and detergent free. But they're available in all different forms. It really depends on patient preference. If patients prefer a bar product and you tell them to use a liquid, they're not going to. So there are soap and detergent-free bar cleansers and soap and detergent-free liquid cleansers. Some of them have ceramides in them already to help with the skin barrier, so they're my favorite. I wish I could give you brand names. Perhaps you could email me and I'd be happy to share them. And the same with moisturizers. You know, a more occlusive form, the most occlusive form is an ointment, and that will trap the most water in. But some patients can't tolerate an ointment because you have that greasy, sticky feeling, and to put ointment on and go downstairs and do things. So for patients with more severe eczema, right after the bath, I recommend using an ointment, and then they can go to bed. But then in the daytime, they might use a thicker cream-based moisturizer. And good ingredients to look for are ceramides especially, but cholesterol and hyaluronic acid. Petroleum is something that makes it very occlusive. We want to avoid anything scented, as you know. And then sometimes if we patch test patients, if we find out they're allergic to any preservatives, that will inform our selection of moisturizers and cleansers as well.
Well, and if anybody does want to send an email to me, Sally, you get my email address every time you get an email from the webinar system, and I can forward that to Dr. Maples if you'd like to do that. So somebody has asked, what is the mechanism of action for TSLP? Are there any significant side effects from TSLP use?
Oh, so TSLP isn't a drug. TSLP is thymexstromal lymphopoietin, and it leads to the production of a lot of Th2 cytokines. It's not something that you use. It's an inflammatory mediator that's overactive in atopic patients.
Well, the next three things are not questions. We have two people that said excellent presentation for you, and another one who said this has been really informative. I love the pics and discussion about different colors to watch for and all the different forms of the spots. Really helpful. So.
Oh, thank you. And hope these photos, I think, for my presentation will also be available on the microsite that Asthma and Allergy Network and the American College of Allergy, Asthma, and Immunology are working on, because we think it's really important to get those images out there. So I'm glad you found them helpful, and you will be able to see those and more later this summer.
Well, every time you answer a question, you lead right into the next one. This is great. The next question is, can a link be provided to the publication you named that will be coming out in August with those photos of patients with skin of color? We're still working on the website, so it'll be a microsite. It'll be promoted through the college as well as Allergy and Asthma Network. So stay tuned and watch for that. And if by the middle of August you haven't seen what you want, pop me an email and I'll write you back and send you a link. Okay, the next question is, are creams with ceramides okay for toddlers and preschoolers?
Yes, and they've even been studied in infants.
Interesting. Cool. Next question is, I work with Native American and Hispanic patients. Their skin looks like the African Americans. Do you have any data on Native Americans, and then said Hispanic patients too, which you've already answered?
I don't. The only thing that I can say is the darker their skin, the more melanin rich their skin, the harder it's going to be to appreciate erythema. I actually saw it in one publication in a major journal that said the erythema is invisible in patients with dark skin. And it's certainly not. We just have to learn how to look for it. So I wish that I had more information in all different types of skin of color, but it's still very limited. So we still have a lot of gaps. But the one thing that you can apply to your Native American patients is looking for other colors of erythema. It may appear more brown or more gray, as we discussed about the African American patients.
Thank you. Our next question is, I'm a school nurse. Is it okay to apply hydrocortisone cream to eczema? That is what I have in the school.
Yes, so the most potent over-the-counter topical corticosteroid available in the United States is 1% hydrocortisone ointment. The ointment's a little bit more potent than the cream, but they're still very low potency topical corticosteroids. So it is safe to put on atopic dermatitis in the clinic. School nurses have an amazingly tough job and you have to deal with a lot, but it's important to recommend to the family that they see a doctor regimen as well. And for lots of patients, the 1% hydrocortisone ointment isn't sufficient. So they may need a prescription topical steroid that's stronger than hydrocortisone, but still very safe.
Thank you.
That should not be a problem at school.
Our next participant said, I'm sorry I had to leave for a minute. Did anyone ask about checking vitamin D levels on these patients and how a low level might cause or exacerbate an outbreak?
I didn't investigate that, but I do know, the new official recommendation is to not routinely check vitamin D levels in the United States anymore, unless you have specific reason. So I'm not aware of any data on vitamin D levels in patients with skin of color with eczema, but it doesn't mean that it's not out there because I didn't search for that.
No problem. Next question is, which of the two strategies for occluding the skin is preferred? Wet wrap therapy versus plastic wrap secured on the skin over moisturizer?
Oh, so we always like to use a breathable fabric, because if you occlude the skin with plastic, the skin can get macerated and it can lead to skin infections and skin breakdown. So wet wraps are a very effective treatment. And when we apply wet wraps in the clinic, we use gauze, but that's disposable, so it can get expensive. So at home, we recommend patients use 100% cotton garments. So 100% cotton socks or gloves or even just pajamas, because that can breathe. You want it to be able to breathe some. And we usually use a damp layer, not a soaking wet layer, because that can cause maceration too. A damp layer and then a dry layer on top. But we do not recommend using plastic wrap. And also recall that anytime you occlude topical steroids, you do increase their absorption, so you can increase the risk of side effects like hypopigmentation and skin of color. So sometimes wet wraps you can do just over emollients alone without any topical steroids.
This is fascinating. Okay, our next question is, I've had students with moderate to severe atopic dermatitis that bathe in bleach. What are your thoughts about this home remedy?
Oh, so bleach baths are another very good treatment for atopic dermatitis. The mechanism of action that we think is responsible for their success is that we are all colonized with staph. So we're not infected, but just staph that lives on our skin. And patients with moderate to severe eczema, they actually make allergy antibody or IgE against that staph. So then it causes a local allergic reaction on the surface of their skin. So by bathing in bleach, you decrease the bacterial colonization and then you decrease that local allergic reaction. So bleach baths can be very effective. You always want to make sure patients have good direction so that they're not overdoing it and that they always rinse well with clear water when they're done and put a thick emollient on it after the bath. But yes, they're very effective for atopic dermatitis.
Okay, thank you. The next question is it a good idea to target the cytokine, I'm going to say these all wrong, cytokinins, pro-inflammatory cytokinins produced by keratinocytes too? Do you want me to read it again?
Yeah, I don't know which, I honestly, I'm more aware of the inflammatory cells that are recruited to the epidermis, like the Th2 cells. I'm not saying that the keratinocytes don't make inflammatory cytokines, but I'm not aware of which inflammatory cytokines the keratinocytes themselves produce, because most keratinocytes are on their way to dying, but that doesn't mean they're not producing, but that's not something I'm aware of.
Okay, we got time for just a couple more questions. Next one is, do certain foods play a part in the dermatitis condition?
So atopic dermatitis and eczema are certainly related. I sometimes tell my patients it was kind of like which came first, the chicken or the egg, because 15, 20 years ago, if a baby had bad eczema, people would be like, oh, your baby definitely has milk allergy because she's bad eczema. And we know that's not necessarily the case. So we know skin barrier dysfunction happens in patients with eczema, the more prone to food allergies. But the presence of eczema itself doesn't mean the child has food allergies. So it's very important not to overdiagnose food allergy in children with atopic dermatitis. We don't want to do what's called indiscriminate food testing, where we just test for a whole bunch of random foods. When we test for a food, we should have a reason, and that's because both skin prick testing and blood testing for food allergy has a very high false positive rate. So that means when it's positive, it can be wrong a lot. So we only like to test for food if we have a high pretest probability, if we have a reason why we think the child is allergic to a food. But the presence of eczema itself just means they need good skincare, they have barrier dysfunction, address inflammation topically, but it doesn't mean that they have a food allergy. And that's definitely a paradigm shift from what used to be. But kids with eczema can have false positives approaching the 90s, definitely over 50%. So kids with eczema in particular have high false positives on food testing, and that can lead to unnecessary food avoidance. And there's some concern that when they avoid the food, they can actually become allergic to it over time through a process called loss of oral tolerance, but that's more theoretical. But the presence of eczema does not mean that the patient has food allergy. If a person with eczema and food allergy eats the food, we expect to see an acute reaction, but after the acute reaction, they may have a flare of their atopic dermatitis.
Okay, great. And our next question is, do you recommend to increase water intake by mouth in patients with atopic dermatitis?
I think that they should have good, normal, healthy hydration, but I don't think they have to have a certain number of glasses of water a day. I think that the most important is the good skincare regimen.
Oh, Dr. Maples, this has been so helpful, and we're already getting so many notes with really positive feedback. So thank you for being with us today. Thank you for sharing your expertise and obviously your enthusiasm for great care for people with atopic dermatitis. Thanks for being here. So
thank you, everybody.
I'd like to thank our participants for joining us today. At this time, please download the certificate attendance from your control panel. If you have any difficulties, don't hesitate to email us using the links in your emails. Please join us next month for a special webinar with the National Association of School Nurses. We will present together on Asthma at School, Coordination of Care. This webinar will air on Thursday, June 3rd at 4 p.m. Eastern. You can register for this webinar on our website at allergyasthmanetwork.org. Look for news in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our recorded webinars on this page on our website. Visit our website for quality guidelines-based resources on allergy and asthma. Also access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network, working each day so we can all breathe better together.